And I'll put it back on maybe when we're doing the questions. Okay, so I'm going to run you through some real world cases for AI in health, just to give you an idea on what's out there, what's already being used, and maybe what's in the pipeline. So, why will that not work? So, the learning objectives of today are to learn about different types of health AI use cases, to explore some examples of where AI in health is currently being used, and to think about some of the implementation challenges that some of these tools have found along the way. So, we can think about this in several different ways, and I just want to take you back to some concepts first. So, when we talk about AI and health, what are we talking about? And so you might see this kind of catch-all type of diagram, which talks about lots of different applications of health, from medical robots, electronic medical records, clinical trials, medical diagnosis. But there are also other ways of looking about this problem. So we can look at the how. So we can categorize things into data-driven kind of prediction scores, so risk scores, triage, monitoring of outbreaks. We can divide things into images and how images are analyzed, and we can divide things into languages and AI chatbots and language support. So that's one way of thinking about it, from actually what the type of AI is, what the type of machine learning, what types of things that we're using. But when we think about these, we're thinking about decision support and workflow optimization. We're not thinking about replacing clinicians. So that's an important part of this. But we could come at it from another angle. We could come at it from the patient angle. And from a patient angle, this section in the middle is about hospital and disease burden. So we could talk about triaging symptoms and prioritizing people for how they need management. We can think about monitoring disease progression. We can think about predicting outcomes. We can think about preventing rehospitalization, symptom monitoring, and managing symptom burden. That's all within a hospital setting. But around that, we've got things like, oh, can you hear me? Is the audio okay from my side?
Yes, we can hear you. I had to mute someone.
Great. Okay. So then, there's other things in this spectrum. This is just about the hospital, but at other ends of that, we can think about providing health information to the patient and predicting outbreaks. So we can think about it from a patient perspective, and this is not exhaustive of all the things that we can think about from a patient perspective, but it's thinking about it, flipping it around. And then we could think about where this is implicated in the health system. So this is another way of thinking about it. Where in the health system is the AI applied? So only part of this down the end is the clinical bit, which is what I was showing on the previous slide. But there are other things. So it could be at an operational level, including supply chain, looking after the facilities, making sure that the lights are on and off, process optimization within clinical trials and development of drugs. It could be looking at the financial side of health systems operating. So the billing, the insurance, the national health system, monitoring where the drugs go and who's paid for medication, and then automating manual and repetitive tasks. So answering calls, scheduling appointments, documenting clinical things. So from a health systems perspective, we can think about it in many, many, many different areas. And this doesn't even include health systems research. So basic research at finding new drug molecules, genomics research at looking why some people are more susceptible to diseases. So there's a whole different way of looking at AI within the health system, depending on what lens you want to put onto that. Having said all that, for the purposes of this talk, I'm actually going to go back to the how And I'm going to give you examples based in these different areas of where AI is being used at the moment. Now, for this, we could talk about a whole load of different pilots. We could talk about things that people are thinking about doing, things that people have got money for doing. But what I'm going to focus on today is tools where they've actually published clinical research that to say the tool is working. There's evidence both from validation of the model, but also when it's put into patients. And then real world performance, where it's actually working in the real world. So that takes millions of possible applications that people have talked about and thought about around the world, and really targeting it down to the ones that are actually being used in real life. Now, I'm going to go back to here. From these three things on this slide, I would like you to put into the chat what you think, which one of these three, data-driven, image, or language, where you think the most progress has been made to actually using these tools in actual real clinical practice. So can everybody just vote? So let's call this, let me just give you these names. Let's call this A, B, and C to help you a little bit. So let's put it in there and see what everybody thinks. So do we think it's A, B, or C? Okay, so we've got a lot of C's in the chat box, quite a few B's in terms of images, and no, a 1A as far as I can see. Okay, so I'm going to go through my slides, and at the end, we're going to see what we think at the end of this in terms of where we are in terms of ones that have actually been taken through. Okay, so like I said, we're going to focus on, I don't know how to close the chat. Oh, here we go. Focus on tools that are clinically validated and are working in real life. So to start with, we're going to talk about screening and images in screening. So diabetic retinopathy is where people who have diabetes have changes in the back of the eye. And the back of the eye is, if you've ever had your eyes tested, they always look at the back of your eye to look for different problems. And looking at the back of the eye can give you ideas about diabetic damage to the eye, but also whether your diabetes is controlled or not, but also things like hypertension. So if you look at this, this is 2018. So this work has been going on for really quite a long time. Since 2018, where the first study was published on this, which showed a sensitivity and specificity of really quite high levels, 87 and 90% for diabetic retinopathy detection. So this is the machine that's used, and it gives some images and it gives a report. So this was the first FDA authorized diagnostic tool with no physicians needed in there. The tool itself gives an interpretation. And actually, this tool has its own medical insurance as if it was a human being. It has an insurance policy, like all doctors have an insurance policy in case they get sued by patients. This machine has got one of those as if it was a human being. It works on convolutional neural network, and what it's doing is analyzing fundus photographs, and it's mainly used in primary care clinics in the US. So for us, that would be like a health center one, or a private doctor in his own little clinic. Now, it can be done by people who aren't doctors or eye specialists, and it gives instant results. Now, in the US, it costs about $101 per scan, and the cost of the actual machine is about 15,000, but then you have to pay for the software as well. So it right now is out of the kind of range of what we would have in low-income countries. And so what are the risks of this? So the risks are that it could miss significant numbers of disease if anything went wrong within the system, or because it's got a, what did we say? It's got a 87% sensitivity rate. So it will miss 13% of diabetic eye disease. Or if you get positive results, so the specificity is 90%, so 10% of the time it will think there is diabetic eye disease when there isn't. So that has the possibility of generating unnecessary referrals because of false positive results. So that's why this specificity and sensitivity is important. Sensitivity can mean you miss things, so false negatives, and specificity can mean that you're over-diagnosing, so false positives. And these both have implications both financially and also stress-wise on patients, and they're things to look out for. But this tool is in use. It's been in use for a decent amount of time. And in the US, where human resources are very expensive, it saves time and money. So Google have a similar one, and actually they have used this much more in lower income settings. So they are trying to use this in India. They have done it not just for diabetic eye disease, but over 50 different retinal conditions. But they're, again, around about the same time, 2018, so that's 7 years ago now, quite a long time ago, it showed some accuracy about 94% for diabetic retinopathy. So it has been used in the UK, also in India. And what this does is, rather than this one, which replaces the physician in terms of finishing the interpretation, what this does, which a lot of AI tools do now, and we'll talk about this in a bit, it actually highlights the relevant areas for the doctor to have a look at. So what this does is, by highlighting urgent areas, it can highlight doctors to the cases which need to be seen quickly, and can cut down delays without actually leaving the clinician out of the loop. The other good thing about this one is, because it's because of the way that Google have decided to run their medical AI, it also really well describes the model. So there's transparency about what models used, and it enables the clinicians to understand how it's coming to its decisions, because it also highlights things for clinicians to have another review. So those are both diabetic retinopathy, which is really the ones that have been going on the longest time and are most well developed and being used. Breast cancer screening is another area where mammography is being used. So in European studies, this is now the way that breast cancer is done is that 2 scans will be produced, 2 mammography x-rays will be produced, and they're both read by independent clinicians, and then they compare their notes. So what this is doing is not replacing both of the clinicians, but replacing one clinician with a AI tool and keeping the human in the loop. And these have shown, and we'll go into a few specific examples, but evidence of being non-inferior. So non-inferior means in a study, it's not worse than the medics doing it. It might be better, but often this is a statistical term that when we're doing clinical studies and we want to show that something is as good as what you're already using, you might do something called a non-inferiority study. So it's not saying that it isn't better. What it's saying is the study has been designed to show that it's the same, at least the same, if not better than what you're using already. So the UK and Sweden are doing deployments and early pilots, but it still needs to be done under rigorous monitoring. So this is an example of one of the most promising tools, the Lunar Insight. And what you can see is that this, again, like the DeepMind for diabetic retinopathy, what it's doing is trying to highlight an area for people to take a closer look at. Now, this particular thing, and there's lots of different things that are looked at in mammography, but this particular image is of breast density, where you're looking at the density of the breast. And sorry, I was just checking that there wasn't a question from you guys. Checking the density of the breast, because density is an indication that there might be an underlying cancer going on. So this analysis was done, a retrospective analysis was done, analyzing nearly 200,000 mammograms, and it gave an area under the curve of 0.9%. Then what they did, and we'll look at how they did this in a minute, how they generated the evidence. So first of all, they looked retrospectively at a load of mammograms and did an area under the curve. Then they started putting it into a real world setting and showed that it reduced the time for doctors to look at mammograms by 37%, but whilst maintaining the very high rate that doctors were doing already. It then started to be used in Korea and in Europe. So in Europe, it got something called a CE mark. I think you remember the diabetic retinopathy tool Insight had FDA approval. In Europe, it had CE approval, so different levels of approvals. This used multiple architectures in order to, as the underlying foundation to the AI behind it. And it's designed either to be used standalone without a physician or in concurrent reading support. What that means is two physicians looking, one physician and one AI tool looking and comparing. Now, I want to use this as an example because I want to give you an idea of what it takes to generate the sort of evidence that will make policymakers around the world think about using your AI tool. So this is a really good diagram of what these guys had to do. First of all, they did what everyone who works in AI loves doing, which is they produced their really pretty area under the curve tools. They tested their model against their training data set. They showed that their model was the best one that was possibly available on their training data set, and that we should go ahead with it. And that was their first paper. They got a paper in a really good journal called JAMA Oncology. There will be a link to all of these papers if you guys want to read about them later. And so that was about selecting the best algorithm, getting the best model working, and then comparing it to what was already out there and saying ours is better than everybody else's. Okay. Now, that doesn't really impress the medics in the room, right? That's just, okay, well, you've got a model that works against your training data set, and it might be better than what everybody else is doing. So then what they wanted to do is look at, and again, with retrospective data, they looked at sensitivity. So, we talked about sensitivity and specificity. So they then looked at sensitivity and specificity as compared to doctors. So on the left-hand side, it's two radiologists with the standard of care. And then on the right-hand side, it's AI and one doctor, AI and one radiologist, with two different versions of their tool. Okay, and that got them another publication. Okay, but this is still not saying it will work in real life. This is saying under experimental conditions, it looks like it might be as good as a doctor, if not better. And then the third paper that they did was, they got the doctor and the AI, and they tried to put it into what's called a clinical workflow. So they decided to see if it would work in real life. So you've got the doctor who says, suspicious lesion, AI says suspicious lesion, or doctor that says suspicion, AI says not suspicious, doctor says not suspicious, AI says suspicious, or they both think it's non-suspicious. Both think it's non-suspicious. They don't do anything about that. That patient just gets told that their scan is okay, because we know that we've got a very high, a 96% sensitivity specificity rate in both of these. Okay, so the chance of it being a false negative is quite low, especially when you've got the two people in the loop. Right, but the ones that were problematic, what they did is then they had two doctors and the AI, so they got a third doctor in there. Again, if it was non-suspicious, they threw them out, and then if it was suspicious, they brought them back. Then they did a biopsy. So then they said, okay, this is a prospective study. They are recruiting real people as they go along. So then they brought those people in to see if they had cancer by doing a biopsy or an MRI scan. And then they decided whether they could confirm that they were confirmed positive or confirmed negative. And what this showed is that they increased the correct number of patients who were recalled for testing. They increased the case detection rate. CDR is case detection rate. So they increased the case detection rate, and they reduced the workload by using one radiologist and the AI tool together. So this is the prospective validation of showing that it actually works in real patients. And then there is a fourth bit that they are doing at the moment, which is, okay, it worked in these particular radiologists who were really excited about AI. They agreed to be in the study. They were keen to try it. And they probably in kind of, I don't know if you've done. Oh, is everybody okay? There's a bit of background noise. Hi, Moses, can you mute, please?
I muted him.
Okay, great. And I'm sure you guys have heard about diffusion of technology theory, which basically that's saying that some people will be early adopters of technology, right? So these radiologists who are taking part in the study, these doctors were probably early adopters of the technology, right? So there is a difference between trying it in those people who want the technology to work and are keen to use it, and people who might be a bit skeptical. So the last step in generating evidence to show that your tool works is by actually putting it into a real life setting. So for those guys who are thinking, oh, I've got a beautiful graph and I've shown that my area under the curve is like really, really high, and I've got my 2x2 tables and they look really lovely. Okay, I'm afraid to say that that's not going to cut it in the real world. There are multiple steps, and it's expensive in showing that your tool does actually work in reality. But we have to start somewhere, and step one is where we're going to start. Okay, so this tool is now being used, this Lumit is being used in Korea, in Sweden, in Japan, and in the UK, but because they managed to produce all this evidence and show all of these results. Coming to our part of the world, the thing that has shown the most promise and has been most useful is around TB screening and computer-aided diagnosis for TB screening. It can be used where there are few doctors, there'd be multiple products approved for TB. And the reason that this was for such an early tool was that actually it came out of COVID. So in the COVID pandemic, when people couldn't get into hospitals, when everybody was scared to go there, people didn't want to engage with COVID patients, everybody was keeping their distance. That's where there was a big explosion in AI around X-rays. And we've realized that actually working for COVID also works for TB as well. So these can be used in mobile vans, such as the one in the picture for low-income settings, but also for places like prisons, refugee camps, anywhere where you might be able to get a mobile X-ray tube. So Cure AI is a really great one for low income settings. These guys started with COVID and went on to TB. So they have done studies in Philippines, Ghana, and Zambia showing 92% sensitivity. So that is, they are picking up 92% of the cases. They're only missing about 8% of the cases. And 95% specificity. So that's only 5% where it looks like it's TB and it's not. Now, the reason why this is important is it's better to be sensitive in TB than specific, because TB can be passed on to other people. So you really want to catch all the TB that's around. So you want to set your sensitivity quite high, so that you can catch all the active TB to stop it being passed on to other people. It does work on other things. So it does work on COVID-19, other chest abnormalities, and there's a paper of it being validated in India. But actually, it's been used in over 100 countries and many scans analyzed. Now, what this does is, again, it doesn't replace the doctor, but it alerts the doctor to places where they need to look more closely at the scans. So if you see on the picture, it gives you a heat map of where they think the problem is with a suspected problem, and then the clinicians can go ahead and look. So if you are a radiologist, what you would do is you would start all the way around here. You would look at the diaphragm, you would look at the spine, you probably have a look at the bones around here, then you would have a look at the heart, then finally you would come to the lungs and have a look at the lungs, and you would look at each lobe individually, and you'd take a long time systematically going through this. So what this does is does that all for you, so you can just go to the area where it's maximum chance of pathology, which reduces the time for doctors to have a look at the x-rays. Again, doesn't replace them. Now, it can be used, interestingly, on the cloud, or it can be downloaded and used in real time. And I think this is the reason why they've had quite a lot of success, is that they've managed to get a system that you can actually use locally deployed on your local internet, so that you are not relying on a super fast internet connection when you're in the middle of the bush in your truck. So they, as well as having good technology, they've thought of ways to make their technology inclusive. It's ResNet-based architecture, specifically trained for chest x-rays. So Cure AI is a really interesting company. There are other companies that have done this. There are other examples. I will put a whole list of papers in available to you. There's about 50 different papers I've got of different tools that have been analyzed. So you guys can interrogate a bit further into actually what tools they've used, as well as the work that they've done. So that's on diagnostics, right? On detecting disease. Now, the next stage, as we saw in the breast cancer, if we go back to here, is that biopsies are taken. So biopsy means taking a piece of tissue, okay, which is the next step in diagnostics. Now, in low-income settings, we have very few pathologists, but getting a good pathological diagnosis is important, because it affects what treatment people might have for their cancer. For things like malaria, the type of malaria is important to make sure the treatment is correct. So pathology is a really important area, but massively undersourced in our part of the world. So prostate cancer was the first AI-powered digital pathology system, again in the US, Page AI. Came out in 2021. And this reviewed 1.2 million prostate samples globally. And this has a 98% sensitivity rate. That's an extremely high sensitivity rate for high-grade cancer. So high-grade cancer is the cancer which is rapidly progressing, and is the one most likely to kill you. So what this did was, from a clinical impact compared to live humans, it actually reduced the false negatives. So it reduced, it increased the sensitivity and meant that we stopped missing some of the high grade tumors. The way it works is it analyzes a whole slide from a microscope, and then classifies, does segmental classification. This has been used in a US clinic and internationally operationalized. But they now have used it for different diseases as well. So stomach, esophagus, and pancreatic cancers. Closer to home, parasitemia quantification for malaria is another interesting area of work. And there are a few tools. AIDMAN is one of them, but there are a few tools that have shown results. For malaria, yes, you can do a rapid test, but on somebody who's never had malaria before or not have it for a long time, or if they're immunosuppressed, the malaria test that we do with the fingerprint is not actually looking for malaria bugs. It's looking at your body's reaction to malaria. And if you've never seen malaria before, or if your body is somehow not reacting in the right way because its immune system is not working, those tests will not become positive. You probably all heard about people in your own countries who had a negative malaria test and then died of malaria. I certainly have many, many, many people I know of in this situation. And so for those people, it's really important that we actually look for real live malaria parasites in their blood. And that's why this is important. But with the little test kits so freely available and microscopy being quite difficult, people don't bother to do the microscopy anymore. Microscopy saved my daughter. I was convinced that she didn't have malaria. She had negative slides. The doctor I met had been working up country, and he said, look, I'm going to start her on the treatment, and I'm going to take the microscope. I'm going to take the slide myself and look at the doctor himself. I'm going to look at her blood underneath the microscope. And he rang me about an hour later and said, yeah, I can see the parasites in her blood. But luckily, he'd already started the treatment. Had he delayed the treatment, maybe she might not have made it. So this is really, really important, but it's difficult for people to do. And microscopes are big and clumsy, and it's a dying art of how to do microscopy. So it's really important that we crack this. So this shows you the attention and the convoluted neural network model that was used. And they've done a prospective validation of this tool. So, yeah. Moving on to cardiology. I don't know who has one of these. I have an Apple Watch, and I bought it purely because my father had a stroke because of atrial fibrillation. And I bought my Apple Watch because I wanted the atrial fibrillation detection. So in over 500,000 people, well, this was 500,000 people when they wrote this paper, but actually many, 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 many more people are using it now. If you think you are having a problem and you press the button, it will record your ECG, and it's got an 84% positive predictive value for atrial fibrillation. So many, many, many people across the world are using this. It is potentially picking up huge amounts of atrial fibrillation. In cardiology, because a lot of cardiology relies on analyzing both images of the heart, but also electrical activity in the heart. Cardiology is an area where it lends itself very well to this type of image analysis work. But also in cardiology, so things like cardiac imaging from CTs, ultrasound, which is a bit like what you guys are learning about, but echocardiography is heart ultrasound, basically. ECGs are looking at the electrical activity in the heart, and then stethoscopes actually listen to the heart sounds. And obviously, as we know, sounds are a great way of voice and sound can also be analyzed quite easily with AI. So these are other types of cardiac applications that have been shown to be working. Skin is another area which is very visual. So melanomas predominantly affect white skin, which is useful because this problems with this. And one of the things that I would like to work on personally, if anybody is interested in joining me for this project, is around increasing, excuse me, increasing the amount of images we have from African and Asian settings around dermatology, but also kind of genital ulcer conditions and genital conditions, so that we can train tools for African and Asian skin, darker skin, for these sort of tools, because at the moment they're only really working in white skin. So that was all about images. That entire section of ones that have been done was about images. We are now going to go on to predictive models, and I know I'm running out of time, Vicky. I'll try and speed up a little bit. And I'm just, before I go on, I'm just going to look at the questions. Okay, they're all about registration. That's good. I will be quicker in these other sections, and you'll see why in a minute. So predictive models and what has been assessed. So sepsis was a big area that people started in. Sepsis was important because diagnosing sepsis is quite difficult. There's quite a lot of factors to consider. There's many clinical signs related to respiratory rate and temperature and age and blood test results. It sort of lends itself well to AI because there's multiple sources, data points that you have to analyze, and doctors are not very good at doing this. Yet the mortality is extremely high. And the success that's happened in sepsis has been around when there are alerts, and alerts are produced for the clinicians, and then the clinicians act on those. But one of the problems that has happened is that actually the models drift. So the models start working to begin with, and then over time they stop working. This is something that we're going to have to deal with in the future. This is something that you guys going into AI for medicine will have to grapple with. I'm not going to say much more about it at the moment, but this is an upcoming problem that we're going to have to think about in the future. So, oh gosh, sorry, I've lost some bits on my slides. I apologize. Some of my slides have gone back. I don't know why. But I'm going to talk about the EPIC sepsis model. So the EPIC sepsis model, EPIC is an electronic medical records system in the US that has thousands and thousands of hospitals using it. And what they did was they developed a model for sepsis, and it worked really well to begin with. And on their testing and training models, and in their first hospitals where they'd taken the training data from, it worked really well. But then when they started applying it in real life, it dropped off. So this then showed, and they're still working on this and still trying to refine the model. And what they've realized is for each setting, they are going to have to train the tool on the data from that particular hospital. So what they learned was around the importance of external validation, and that you've got to keep iterating your model. You've got to adjust for this model drift, and you've got to apply it to your particular population. There's also another one about ICU. I don't know why the slide is missing, but I'll add the data in here, or find the slide and share it with Vicky. But basically, with ICU readmissions, they were using similar data. They were trying to predict who would both be most likely to come back to ICU. So who was really sick, then they got discharged from being really sick. They were not ventilated anymore. And then they ended up in ICU to see if there were things that they could do. And again, models worked well in local context. They worked well for hospitals for a certain period of time. And then they just started to drop off. But also, they didn't transfer to different hospital settings. So, again, sorry, I don't know what's happened to my Oh, my slides. Sorry, there's a bit of a challenge with my slides. But anyway, the next thing, so that was on predictive algorithms. Really, only those two, the symptom check, the sepsis and the ICU ones, are two of the only validated, tried and tested in real practice predictive algorithms that are being used, and they're both used in the US. When we come to natural language models, chatbots, symptom checkers show variable performance. There's some parity in controlled tests, but in reality, they're very difficult to get working. They're being used for health promotion, being used for chronic self-disease management and appointment navigation. But in terms of showing impact and in terms of showing real world outcomes, we're really failing to generate evidence on whether these things work. So there are a few that I can point you to in our part of the world that are working well, but it's very difficult to say that these are showing improvements in people's health because the evidence is just not there yet. So again, it comes back to what I was saying at the beginning. I'm not giving you examples of all of the possibilities that are out there in the world. I'm giving you examples where we've managed to generate enough evidence to show these things are working. So these are some examples Jacaranda Health does, and these are all, a lot of these around maternal health. Jacaranda does maternal health in Kenya. MDoc works with women in Nigeria, Mum Connect in South Africa. Now, the reason why they can show some results is that pregnancy only lasts 9 months, right? Whereas some other health conditions, you've got to follow people up for 10 years. So pregnancy is quite a good thing to generate evidence quite quickly because there is an outcome that happens after a certain period of time. And in most things in health, that doesn't happen. However, we are yet to see large-scale population-level improvements in health because of these things. So, implementation factors and challenges. What are the things that allow these tools to work in real life? And what are the challenges ahead of us as we work in our multidisciplinary teams? And the reason we brought you together in the hackathon as multidisciplinary teams is it's all very well generating an area under the curve graph, right? Or a 2x2 table. Okay. You are going to need medics and a whole host of multidisciplinary stakeholders in the team to get this tool actually working in practice. So, what have we learned from some of these studies? Well, first of all, lab versus real world performance is sometimes off, and external validation is essential. We need to use AI to augment rather than place clinicians. And for those of you who were in my first talk about governance and bias and safety, it comes back to this. We are not looking to replace nurses and doctors and lab assistants. We're looking to support their work. In order to get AI into workflows, often those workflows have to be redesigned. If we take the example of the mammography, we had to change how the doctors were working. They worked with an AI tool rather than with another doctor. And you've got to keep monitoring this with performance drift. Performance drift is quite, I mean, we could do a whole lecture on performance drift, but it's quite a big problem with these tools when they're placed in real life. Evidence standards. So all the things that I presented have had peer-reviewed publications. Most have and peer-reviewed publications in medical journals, not in computer science journals. So showing that they have an effect on the patients. Most have regulatory approval. They've demonstrated that they work in real life settings beyond the laboratory. So what are some of the common success factors for these models? Well, can you remember the size of the training data set for the prostate cancer? It was 1.2 million scans, right? These are large data training sets that people have done. They've done prospective validation studies, so they haven't just looked retrospectively. It's clear how they're going to be integrated in practice. They've got regulatory approval, and they do ongoing monitoring. So what are the things that we can do? What can we learn from this? So we ought to prioritize high volume tasks with clear outcomes. So the reason that TB is successful is you've got an awful lot of x-rays to look at. and you know what the outcome is going to be, right? So it's a really high volume, clear outcome. You've got to use local data to fine tune it. And then you've also got to do your calibration and revalidation in all of your SOPs as you're moving forward. So, how do you work with the clinicians? How do you change management? Well, it's important that you co-design these things with the clinicians in the first place, mapping the pathway from end to end. The clinicians and the patients need to be involved all the way along the way. You need to do training of trainers, competence checks, and always have a human in the loop. And then you need to monitor. You need dashboards that help easy monitoring of the tool. Is the tool still working? Is it still doing what it's meant to be? Are the sensitivity and specificity dropping off? What's it doing to the turnaround time? Equity, coming back to the fairness. Are all patients being offered the same tool? So this is recent studies from the UK. Now, remember, this is the UK where everybody's heard of AI. There was recently a study done in South Africa where 2/3 of people in South Africa only had heard of AI. A third of the whole population didn't even know what AI was. And that's South Africa, right? So in our populations, it's likely to be a lot less. But 1 in 6 people thought that AI was going to make things worse. 2 in 6 thought it was going to change. 1 in 6 didn't know. And only about a third of people thought that AI was going to improve healthcare. So this is something that we're going to have to grapple with. We are going to have to take people with us in this journey. We talked about this in my last lecture. Just a reminder, data protection, bias, and procurement. Let's think about if we're going to procure tools, if we're not generating them ourselves, if we're buying them, we need to think about liability. Who's responsible if the AI goes wrong? Is it the doctor using the tool? Is it the hospital? Or is it the software designer? Whose liability is it? If things stop working, can we get out? If there's a performance drift, can we stop using the tool? What guarantees are there? And when you're thinking about it as designers, you need to think about, as developers, these things will come up when you're trying to sell your product to people. Sustainability, cost and sustainability, we need to think about all of these things, the total cost of ownership, whether we can have offline first, and planning for the future. Now, last slide. Africa-led innovation. So let us go. We've been talking about federated learning last week. We hope that you've taken that on board. Low compute options, mobile first imaging. So can we look at images where they're collected out in low resource settings, not just in high-end hospitals, like our low-cost probe, really making sure that they are out. The tools that we're creating will work out in the places with the people in lower resources. We're doing an awful lot of work, and we under HASH are doing a lot of local language LLMs for patient education. Just because I didn't talk about LLMs in here doesn't mean to say that not millions of people are coming up with LLMs. What I'm saying is that they haven't been clinically validated. But there are lots of amazing people working on this kind of work, both for educating patients, but also doing things like generating digital records. If we're going to analyze patient data in our part of the world, we need to rapidly increase the amount of digital records that are available. And LLMs, speech to text, can really help us do that. But we also need to be creative. And this is what I'm going to spend my life, hopefully, over the next few years working on, is how do we create regional evaluation hubs and biorepositories? How do we make sure that within both Africa and also low-income places in Asia, because I know this group is not just an African group. We have our Nepalese and our our Pakistani colleagues, how do we make sure that we have regional evaluation hubs, biorepositories, and that we can do our own evaluation of our own tools? Thank you. I'm sorry I went a bit over. As you can tell, I'm kind of really passionate about this subject. So I got a bit excited. But I hope it was useful and interesting for you guys. And I'm happy to take any questions.
Thank you so much. I think you can see the love and the reactions. Thank you so much for taking us through real AI cases. I don't see any questions. I'm waiting to see if there are any questions that are coming in, but there's somebody who posted about the mobile TB clinic in
Yeah, so there's a TB one in Uganda. So so like I said, there are things that are being used under the TB section. The WHO has also got a very long list of lots of different tools for TB that have been approved. It's just that I concentrated on ones where they've got they've got peer support, peer-reviewed publications related to them. But yeah, I mean, many people are now using this, which is great. Hopefully, we're going to revolutionize TB treatment. Thanks.
All right, thank you. I don't see any other question. Somebody has said it was an excellent talk. I think very self-explanatory. Thank you so much. I think if there are any other questions, we will forward them to you through the learning management system.
Okay, no problem. And what I will do is there is a whole list of publications which might be useful for you for the future. Like if you're writing grant applications, it's useful to have a list of publications that you can reference. But also if you go on and do a master's or if anybody's doing learning. I'm going to, Vicky, are we able to upload Word documents rather than PowerPoints, or does everything have to be a PowerPoint?
No, you can upload Word PDF.
Okay, so I can upload it as a PDF. So I will upload that in the documentations. Thanks.
And someone has their hand up, Victor.
Oh, yeah.
One.
Yeah, thank you very much, Paki. That was a very nice presentation. Yeah, can you hear me? Am I audible?
We can.
We can hear you.
Okay, yeah, thank you very much. That was a very nice presentation, very self-explanatory. I'm coming from the social perspective, because I'm a medical sociologist, because like we stated yesterday, most of what we are saying here find a very good ideas, but the most people who are mostly affected, who have more mortality cases.
Victor, I'm really sorry, but your sound is not very good. Are you able to type the question? Because it might be easier. I'm really sorry. Unless anybody else can, Vicky, if you can hear better.
No, it's a bit unclear. You want to try again, Victor?
Yeah, or type it. I think I heard that you're coming from social sciences background. Is that right?
Yes.
Do you want to try again?
Can you hear me now?
Try posing the question again and let's see. Give it a go.
Yeah. What my concern here now is the rural people, the rural area, because that's where most of the mortality cases or cases of maternal mortality, most of the TB can be recorded due to social factors, determinants within those social environment and the ecological factors within those place. Now, in creating using an AI to leverage to bridge this gap, because most of them the distance, because the work I do on 4 P's of health, accessibility, affordability, accountability, and one other one. These factors can also influence them to get good health care. So in creating a good AI tool, which that we made mention of internet accessibility. How can we train this model in order that these people in the interior rural area can access the tools for their healthcare or to detect whatever problem it is? Because if that is possible, then the mortality rate or fertility rate will reduce drastically. Thank you.
Okay, so if I've got you correctly, what you're saying is that the maternal and neonatal mortality is multifactorial. It's not just about accessing healthcare, it's a lot of other social factors. And is there a way of addressing that with AI? Is that correct?
So how can we address this in creating a mobile, either a mobile app or a mobile clinic that will be void of internet disruption? That even without the internet access, the tools can be trained to detect and to provide the solution.
Okay, so I mean, first of all, I would say AI is not going to solve every problem that we have in the world. And there are social and structural and intersectional problems related to poverty and gender and education and health that are going to be very, very, very tricky to address. However, having said that, what I would say is that if we want to create AI solutions that are going to deal with some of these tricky issues for our populations, the first thing that we need to do is to start working with those populations to really understand where the pain points are. So doing community engagement, doing focus group discussions, doing stakeholder consultation, and really trying to understand what the problems are, and then separating those into ones that we may be able to do something about with AI and ones that we can't do something about with AI. But really, if we want to grapple with this, we need to work with the population. So you would start with some social science work. You're a social scientist. You would do your normal social science methods, but you would have an AI lens on there. You'd talk to people about what AI is, you'd build their capacity, and then you'd engage with them and really try and think this through. And then you would come up with a tool. You would then show it to that population. You would check that it meets their needs. You might have to do a couple of rounds of work. And then you would start to pilot it to see if it worked in this population. And then you may have to change it again, right? This is a long journey. This is not a quick journey. And then you come out at the end with a tool that is relevant to your population and that can start to try and address some of these issues. The beautiful thing about AI in terms of language models is it can be empathetic and it can be personalized. So you can start to personalize some of the content for your particular population and even particular individuals with a particular profile in your population. So we've got the ability to do that. But it's a long and complicated journey. And I wouldn't want anybody to think that AI is going to be the solution to all of our problems. We are going to have to, as human beings, keep working on, these intersectional problems that our populations have. Thanks.
Thank you so much. I believe this has been a very good engagement, and we will be providing the presentation, the recording as was requested. Thank you so much, Dr. Ross. We will catch up later. Next, we have Dr. Pradeep, who was here yesterday. Today, he's going to be taking us through integrating the data, the obstetric data, integrating AI into obstetric ultrasounds. So welcome, Dr. Pradeep. I think I already made you co-hosts. You should be able to share your screen.
Thank you. Thank you. Good evening from Nepal. And let me share my presentation. Now, is it visible? Yeah.
Yes, it is.
Yeah. Thank you again. And today my topic is integrating artificial intelligence models in obstetric ultrasound in regular clinical workflow. So today's outline will be what we have learned so far. Yesterday I took two lectures and about the clinical relevance of obstetric ultrasound, what can we do for artificial intelligence, and how we can coordinate between the AI scientists, researchers, with the clinicians, and interpretation of AI models into regular workflow. So today's, and I'll be talking about artificial intelligence in obstetric ultrasound and its capabilities and uses in trimester specific tasks and challenges and mitigation strategies in integration of artificial intelligence and future directions. So why AI in obstetric ultrasound in our setup? Because we have to deal with very high volume, and ultrasound is obviously an operator dependent modality. What the brain has, the eye sees, so that must be difficult to interpret for all the non-radiologist, non-sonographers, so it must be standardized. And there is potential for early anomaly detection through AI in the peripheral setup so that it can be transferred to the higher tertiary level center in the country like ours. So ideal scenario, ideal package of obstetric ultrasound could be integrating with using eye tracking, voice recording, transducer motion, and ultrasound video. So all this compiling, if it is compiled like what the radiologist look into the ultrasound image while looking the head of the fetus and how the probe is moved in accordance with the visualization of the image. So that must be an ideal setup for artificial intelligence to build a model in terms of it. So, but in our country like Nepal, there is about 200 cases of ultrasound per day in high volume obstetric centers. So there is issue of burnout, and for all radiologists, sonographers, ultrasound technicians, so that there is definitely a need of AI for other health professionals like midwife and nurses in the peripheral part as well, to decrease the maternal morbidity and mortality and come up with higher fetal outcome. So AI can work as a bridge, and it work between the task shifting and point of care ultrasound. And if we can integrate this point of care ultrasound, integrate with AI, then definitely it can help in the high volume centers like ours. So, and there is one interesting study which is done in coordination with our institute in the past, and they have studied about the accuracy of home-based ultrasonic diagnosis of obstetric risk factors by primary level healthcare workers in rural Nepal. Actually, they did not use the AI, but they trained these primary healthcare workers for 2 weeks, and then they check the accuracy of their performance for only on the basis of third trimester ultrasound for selected patients. So in this study, they did about the minimum auxiliary midwife nurses were involved, and the 3 participants were there and received 2 1-week training in our department where I work in the capital city, 1 month apart. And then they trained to diagnose fetal presentation, fetal number, heartbeat, and location of placenta through the ultrasound. ultrasound devices, which is available and it is done in Sarlai district, which is peripheral part of Nepal. And total of 804 women were included in the case. And for the presentation, number of fetus, heartbeat, and location of placenta, the presentation was most accurate in comparison to the standard radiologist. So their sensitivity, specificity, positive and negative predictive value were between 90 to 100% with this short-term training. So they can be used in our setup nicely to screen some of the important aspects in third trimester ultrasound, which can definitely help to prevent the morbidity and mortality of the pregnant women in the setup. So definitely AI can help with this also to integrate into the point of care devices and work in the peripheral part as and challenges for implementation within this peripheral ultrasound clinic or point of care devices. There is a high likely chance that there would be misuse in terms of non-radiologists using ultrasound devices or skills for private practice in rural setups, for sex determination, for illegal miscarriage as well. And this is one of the burning issues currently in ultrasound in Nepal in the peripheral setup, where non-radiologists are doing some illegal practices there with for the sake of money. So the Nepal Radiologist Association was bound to put this notice for the healthcare professionals and other non-clinicians that the formal report of the ultrasound or any radiology device modalities should and must be done only by radiologists, and the formal report with signed is only allowed for the radiologist, not the other clinician. Other clinician can definitely work with the ultrasound, but for the sake of the patients in hospital setup or without getting money for that practice. So in Nepal, ultrasound may be done in comprehensive manner with the formal reporting only by radiologist. I am reading their points. And at points of care, in the absence of radiologists, sonography must be done to answer focused questions, and it must be done by at least by qualified medical officers. They should record the findings and impression in clinical notes. No separate formal report can be given, or additional charges should be incurred from the patient. This is the strict notice which is which Nepal Radiologist Association published it in the newspaper. And there are some challenges in artificial intelligence in medical imaging, and there is one interesting study in 2020 how the perception of AI is changing in radiology field. This is a study done by American College of Radiology. It is done in 2020, and there are about 1,400 responders, and 33% were using AI, and 94% said that it is inconsistent back in 2020, and only 6% said that always worked, and 2% said never worked. But along European Society of Radiology also published another paper comprising 690 responders. 40% was experiencing using AI. So Europe and America during 2020s, approximately 35 to 40% radiologists were using AI for their regular practice, and only 14% said yes, definitely wanted to acquire AI, and 52% said no. But in 2024, there is another paper of impact of AI and radiology in this European Society of Radiology. And in this survey of 572 responders, 48% said that AI only reports are not accepted by the patients. For 48%, according to 45%, radiologists will take the responsibility of AI outputs. So radiologists are now a bit more convinced than previous to use AI for their decision making, and 48% respondents were using AI. So there is a huge improvement of the radiologist using the AI. So definitely a use of LLM is not only limited to research. So AI tools will enhance clinical efficiency, but require human oversight for patient acceptance. So education of AI is quite needed. So it is the highlight of their survey in 2024. So there is another paper which is on AI in obstetric ultrasound, and it is there was a survey in obstetric ultrasound. What are the things priorities for artificial intelligence assisted obstetric ultrasound in LMICs? And this survey also comprises 176 respondents across the South Asia and countries of Africa as well. And they found that the assessment of gestational age, fetal viability, fetal presentation, and multiple gestation were the most common uses and among the most highly prioritized for AI-assisted obstetric ultrasound development. So these are the main four priorities for AI for integration into obstetric ultrasound. And some expressed reservations on AI-assisted ultrasound, and 71% said that they are not understanding the technology. Other 62% were telling that there were misdiagnosis and the cost is high in the perception of 59% of people. So these are the some uses, and mostly obstetric ultrasound is used in the LMICs for gestational age, fetal viability, fetal presentation, and number of gestation, and amniotic fluid volume by their survey. And high priorities were obviously gestational age, fetal viability, fetal presentation, and ectopic pregnancy was also there, one of the priorities for obstetric ultrasound in LMICs. So these are the outcomes of their survey. And what are the challenges and limitations of AI in obstetric ultrasound? Probably biases could be there because of the low number of data sets. Like I said yesterday, in case of ectopic pregnancy, and there is a huge and less number of data for AI model to create. And another will be misuse of, as I have explained earlier. And other is the data privacy and security breaches that could cause patient harm or propagate health inequalities as well. So AI-assisted obstetric ultrasound is a tool and not sole substitute for strengthening of the health system. So other challenges can be adaptive learning, because there must be ability to learn over time. So it must be fine-tuned over time to change to imaging equipments or protocols and software update as well as. And FDA clearance does not guarantee AI algorithms are generalizable. So our role should be products should be locally validated with data from environment where they are supposed to work. So these are the challenges. And yeah, obviously there's notice I already showed. So in radiology, how can we integrate AI in radiology? One can be interpretative, another can be non-interpretative form. Interpretative form can be for the diagnosis, like breast imaging, lung cancer imaging, breast cancer imaging, neuroradiology for strokes, or MSK radiology as well. And non-interpretive, like improving the workflow, improving image quality, and triaging the patients. So these are the forms which can be used in radiology. So the barriers can be these are the common barriers which are highlighted by the clinicians. And medical legal issues is one of the thing which is going on. Dispute is going on, debate is going on. So AI in obstetric ultrasound there can be used in our workflow as there is three important pillars for medical education. One is radiology education, one is research in radiology, and clinical service. And for education, we can integrate AI. For research, we can integrate AI and clinical service. So it doesn't guarantee that every AI model used in research will come into clinical practice. So it is our challenge to mitigate. And in radiology education, we can use this data set, either it is clinical, pathological, or imaging in a data server, and that AI server will serve as a teacher control, and teacher will control that server, and student will uh, uh, get these data sets for individual study and online exam as well. So this can be used in radiology examination. And for interactive learning as well, they read the images, write the images, and they get the feedback from AI analysis with report, and they push relevant teaching points through AI, and there will be a growth curve and push relevant cases to the students who requires, and there will be a communication between the teacher and the student. So this can be used as interactive learning model as well. And another could be for self quiz for the students, randomly select cases, read images, and diagnose from that data set, and scoring will be automatized, and this can be used as a teaching learning activities in radiology education. So, and another is the online exam as well. So they can be automated random number of questions to the students, and they give tests and they score, and then they print and export the exam papers, and exam analysis and summarization will be done by AI. So this can be used as a in radiology education as well. So yesterday, this was the main purpose of the clinical relevance, and these are the areas which AI can be used in obstetric ultrasound, either in emergency as well as in regular outpatient setup as well. So first trimester, second trimester, and third trimester specific uh, important things can be taken from the patients and transferred to the clinicians through AI. With AI can facilitate that. And now, if it's right artificial intelligence and pregnancy, you get 7,152 articles in a year. So it is quite a hard topic going on, and benefits are there, and there will be faster reporting, decision making will be there, standardization will be there, and supports the junior clinicians or radiologists as well. And obviously our target is to improve prenatal outcomes. And in first trimester and second and last trimester, there can be application. In first trimester, then that can be detection of uh, anomaly as well. In as I showed yesterday, detection of nuchal translucency or any limbs can be detected with AI models, and automatic measurements can be done in second and third trimester, and even neurodevelopmental maturity prediction or diagnosis of growth restriction can be done, or another could be assessment of fetal lung maturity and diagnosis of congenital heart disease in second and third trimester can be there. And another interesting thing is evaluation and prediction of premature birth by cervical ultrasound, and AI can help with this to grade the maturity of the cervix during the pregnancy. And evaluation of fetal weight and gestational age is one of the uses that can be applied, and AI can facilitate for obstetric ultrasound. So application of first trimester fetal growth and development can be done in 2D format, or and that 2D can be transitioned to three-dimensional image as well from that 2D image. It can help. And in first trimester, we can automatize measuring the crown rump length in embryo, and it can be measured automatically through 3D segmentation or after maintaining the proper sagittal plane from the clinician. So this can be done through AI, and early pregnancy detection less than 6 weeks can be done, and many a times it is harder to get these ideal images through transabdominal ultrasound. So we commonly use transvaginal scan for early pregnancy detection. And fetal heart rate would be one of the application. can be integrated into a AI module. And another would be incorporating with AI the fetal echocardiography and cardiotocography also to access the fetal congenital heart disease. And if the video clip of the fetal chest can be extracted and make integrated into AI model, then obviously the expert can review for congenital heart disease from peripheral setup to the city areas. And these are the planes we usually use for fetal congenital heart disease detection. And obviously, if we can generate this sort of planes from one clip of the chest, it definitely helps to detect the fetal congenital heart disease because to get to this anatomical plane, it is very much harder if the fetus is not in optimal position. So the AI can be integrated for this also with proper annotation and proper data set. And ectopic pregnancy is one of the hot topic. Yesterday also we discussed about it. Can detect, and there are some studies done in ectopic pregnancy, but not has high accuracy as probably because ectopic pregnancy doesn't land always with fetal beating heart. So it can land up with some hematoma or some collection, as I said yesterday also. So another would be nuchal translucency scan or early trimester anomaly scan to detect whether to suspect any trisomy in the fetus, and to measure or detect the nasal bone. And nuchal translucency is important in early anomaly scans. And so this way, nuchal translucency can be automatic segmentation can be done and can be measured between these two lines, and it can be integrated with regular workflow. Other second trimester scan, I discussed it yesterday as well. We measure biparietal diameter, head circumference, abdominal circumference, femoral length, and it can be integrated into AI models so that it is easier for getting the reports as early as possible, and standardization of the reports through in the peripheral part of the country. And so and even not only measurement the fetal weight, it can also detect the cranial abnormality, brain abnormality as well. So internal structure can also be trained so that it can detect normal or abnormal. So in fetal head, measurement is already there in lots of machines, but we can create the model to get into the internal structure of the brain, like lateral ventricles, cerebellar diameter, or cisterna magna, or corpus callosum. And corpus callosum is one of the hardest structure to get by even well-trained radiologist, because not every fetus have lie in a proper plane to detect that corpus callosum. And if we can generate the corpus callosum out of the 2D images of biparietal diameter, that will be very much helpful for us radiologists also. And another would be automatic recognition and assessment of fetal facial structure. Like many a times we do not get ideal facial structures without hindrance. There a lot of time there will be a umbilical cord or the fetal limbs, as well as hand or leg also. So if we can automatic recognize and assess this facial structure, it can be of help, especially to detect cleft lip or cleft palate in clinical setup. And obviously the challenge is proper position. So if it can be generated with segmentation, it will be awesome for us. And another, as I said, these are the internal structures of brain that can be done through the train data set for detection of the internal brain anomalies as well. So these are the most common anomalies we get, like ventriculomegaly, hydrocephalus, or corpus callosum anomalies, or posterior fossa anomalies. So this can be detected with combinational algorithms. So another would be measurement of fetal abdominal structures, and automatic positioning can be one. So, and another would be measurement, and if the plane is not properly accepted, then AI can guide the health workers to get to the proper plane through AI model. So that can help. And other can we can do is that organ specific measurements like detection of fetal kidneys, urinary bladder, gallbladder, liver, and adrenal glands. This can be important in suspected cases of congenital anomalies in fetus. So this can be integrated into our ultrasound machines. And another important aspect could be detection of long volume. And long volume, because sometimes we get cases of diaphragmatic hernia, or any hypoplasia of some part of the lung is not properly developed. So it can we can prognosticate this fetal maturity from this volume of the fetal lung as well. So this can be important, and we can grade this. If we can grade this automatically or with the models, it definitely helps. And another is the position and presentation of fetus, and with relation to cervix. And cervix is quite important during second and third trimester, and we have to look the cervix, and if it can be detected with the model, if it can be helped, it will be definitely can decrease the fetal mortality in the peripheral part as well. And shape of the cervix, I told yesterday, it is important because it can prognosticate the cervical incompetence during the early trimester. So the shape of the cervix is also quite important for us clinicians. So we can detect this length, shape, and the orientation of the fetus together, so that it helps in proper guidance of mode of delivery. And uh, and recently there are quantitative analysis of tissue texture uh, by images, and probably it can be the main application point for AI in evaluation of cervical insufficiency. So there is one study they have done in Spain, and they have done analyzed quantitatively the texture of cervix in correlation with gestational age. And uh, with the gestational age, there will be softening, ripening, dilatation, and repair of the cervix. And with this texture evaluation can help for prognostication of the delivery. Premature cervical ripening can be detected in early trimester, so that it can prevent spontaneous labor. So this is one of can be applied for AI integration in our ultrasound machine. And another yes, and the fetal presentation in relation to placenta as well as the cervix is quite important. This can be integrated, and AFI measurement of amniotic fluid index can be done, can be integrated in AI, and placenta is quite important. As I have as I am giving emphasis on placenta, because it can definitely help to reduce placenta fetal mortality in periphery, because with midwife doing the ultrasound, sometimes it is harder to get to the whole length of placenta. So the devices can help and localize the placenta, so that the peripheral midwife can help or can refer the patients in time to the peripheral to the tertiary center. And placenta and preeclampsia is quite correlated. And preeclampsia is due to abnormal development of placenta, and there can be detect, and there are blood tests to predict preeclampsia, but in our peripheral part, it is the issue of cost. And this placental growth factor, tyrosine kinase, cell-free DNA cost many dollars for the periphery. So if we can detect this prognosticate this preeclampsia, we can definitely help. AI can definitely help. And there are recent innovations, AI methods in placental pathology, and most of them are detecting the maturation of placenta in regard to gestational age. This can help in detection of preeclampsia or morphological analysis, 3D segmentation of placenta and placental health. This can improve understanding of placental health in if it is integrated with AI and regular or ultrasound machines. So Doppler studies, I talked about it yesterday. It can help for umbilical artery Doppler, and it can automatically detect whether it is abnormal or normal, so that it can be alarming for the fetus, so that the midwife can go for a early delivery. And middle cerebral artery is another Doppler study we commonly perform. This can be also integrated in our machine. And uterine artery is also done in early trimester for prediction of preeclampsia. So this can be done, and these are the things which can be integrated in our ultrasound machines. And another is Doctor's venosus. Also, it is hard to get. So if a model can auto segment it and get into our automatically, so it can be definitely help for intrauterine growth restriction or fetal cardiac compromise. So there are challenges for this, all this integration. So challenges can be obviously data in our setup, and another is annotation challenges or data privacy. So and the inconsistent manual image labeling issues can be there. So this can be mitigated through federated learning, data augmentation, synthetic data generation, or standardized protocols. And another would be challenge would be algorithm development and validation. So image, all the images are variable. Not every image can be same all the time. So there is complex anatomy. So there can be accurate segmentation requiring sophisticated models to detect this complex congenital heart disease like things. So this can be and explanatory is another challenge, and generalizability and robustness is another. So this can be mitigated through different clinical trials or the ensemble methods combining models that enhances accuracy and robustness. So this can be done. And other regulatory issues can be there can be issues of regulatory approval, liability, accountability, biasness, data ownership, or informed consent. So this can be mitigated through collaboration with regulatory agencies and establishing ethical review boards for the AI module development and deployment, or develop clear legal frameworks on the in LMICs. And clinical adoption and workflow integration can be the issues, but with proper clinician test trainings and customizable alerts and patient specific modules with proper training and education, this can be integrated into our system. So user acceptance will be higher if there will be transparency addressing concerns involving clinicians in AI module development. So this can be done. So integration roadmap can be applied in pre-implementation, peri-implementation, and post-implementation framework. And pre-implementation can, in terms of data curation, model selection, or stakeholder alignment would be there. And clinician training and workflow integration can be done in second step, and implementation monitoring, feedback loops, model updates can be there. So it is a if this integration roadmap can be followed, we definitely can integrate AI models in our clinical ultrasound. So coming to my last slide, ultrasound is a non-invasive imaging modality and operating dependent. Integration of AI definitely helps in obstetric ultrasound. So for task shifting, faster analysis and image generation, and even microscopic analysis or texture identification can be done in cases like cervical incompetence or preeclampsia. So we have to integrate this AI into obstetric ultrasound for better detection, diagnosis, and early treatment of the patients eventually benefiting the society in low and middle countries like ours. So thank you.
Thank you so much. I hope you can hear me.
Yeah.
Okay, all right.
Thank you.
Thank you so much for your presentation. I believe you can see I don't know that you can see the hand claps. People never see the hand claps when they are on sharing mode. Yep, there's a lot of hand claps. All right. Any question? I've seen Victor's hand being up. I don't know whether he put it down. Victor? All right. All right, so let's get any questions directly from the chat, if there are any. I think today's session, as we wait to see whether there are any questions, today's session has really been very, I would imagine, effective, very great at understanding how AI goes into the health sector. Additionally, how to make sure that your health AI innovations are actually accepted by clinicians. I think that's one of the key takeaway messages. We've actually seen why it's important for AI to be integrated within, especially in the radiology side of things. So these are things that you can continue working on. And I think that last slide has got the best message of all: better detection, better diagnosis, and early treatment. So regardless of the disease, I know this just points towards maternal health, but regardless. All right. Any questions? I know Victor said he has no questions. Any other questions? Israel, yes, you may go on. Just unmute.
Yeah, thank you so much, Raj. It's been a very insightful presentation. So I just need clarity on the data concerning the use of AI in obstetrics. There was a slide where you shared a kind of survey. So I wanted to know, is the survey done in Nepal or in your region, or is it a global survey? Thank you.
The obstetric ultrasound, that survey is done in low and middle income countries, and the people from GE Healthcare did that. And one of the author, Kyla, is a friend of mine, so I shared this. And they did in some countries of South East Asia as well as some part of Africa, I think. So it is a global thing.
Thank you. Thank you for the clarity.
All right. I think the slides are already up. There are some resources, additional resources that will be put up, some PDF just for you to review. But any other questions from the group? I don't see any hand up. So I'd like to really thank you, Dr. Pradik and Dr. Ross. I know you're still in. Thank you so much for this session. It was very effective. And I do wish all the participants a great evening. If any questions arise, you can always post them in the LMS. We'll see you all tomorrow for the final session as I give you some updates tomorrow. Thank you.
Thanks so much. Bye, everyone.
Thank you. Bye.
Bye, Dr. Pradeep. Nice to see you.
Bye. Nice to see you too.
Take care. Bye.
Bye.
Thank you, Victoria. Thank you, Pradeep.
Thank you.
You're welcome.